słuchać naszych gości z zagranicy. No tutaj już parę razy podkreślali przedmówcy, że dzięki forum będziemy mogli rozpoznać te sprawdzone w innych krajach praktyki i standardy, zobaczyć, jak one są wykorzystywane na polskim gruncie, zobaczyć, na ile mogą być wykorzystywane po prostu jako takie, na ile trzeba je dostosować do Polski. No i też chętnie posłuchamy oczywiście o tych błędach, bo rzeczywiście zgoda, że z porażek chyba płyną najgłębsze lekcje i jak tych porażek nie ma, to można się obawiać, że coś jest nie tak. I są z nami ci najlepsi na świecie i w Europie specjaliści. Pierwszym z nich, którego zaproszę na scenę, jest pan Andrew Meyer, jeden z liderów NHS Digital, twórca brytyjskiego Digital Delivery Center, odpowiedzialnego za rozwój usług do obsługi, uwaga, 60 milionów obywateli. Jest z nami. Zapraszam. The floor is yours. Welcome to Sopot. Yes, with this microphone, okay.
Thank you. And let me put this somewhere safe. Thank you for inviting me to talk again about the work that we're doing at NHS Digital. It seems like only 5 short months since I was here last, so it's a real pleasure to be here again. I was also taken by the Minister's comment about failure, because actually that goes with success, and you should welcome failure as much as you do success, because that's the only way you're going to learn. The only comment I would make is make sure that, or try and fail fast rather than leaving it to some point in the future. So, I'm Andrew Meyer. I run something called the Digital Delivery Centre at NHS Digital, and my team build some of the national services for the NHS. NHS Digital is the national delivery system for the NHS in England, and it provides some of the national infrastructure that helps the NHS work and talk to each other. We also have some statutory obligations around publications. So all data comes into NHS Digital, we summarise it and then use that for publications. So there's some of the things I'm going to talk about in the next 15 minutes. So it's really important that we have a vision, and ours has changed a number of times over the last few years, but actually the main theme has been there all the way through, to make health and care better through the use of IT. Fine having a vision, but you need some sort of blueprint or mission in order to reach that vision as well. And it's important that we do have those pointers and plan to actually help us get there. Our mission consists of a number of elements, from empowering the person or the patient right through to creating the future. But arguably, the most important part is the infrastructure that supports all of those things and underpins everything that we're trying to achieve. So hopefully some of you will have heard of the NHS spine. I'm going to test out a video. I think it's only the second time it's been seen, so bear with me, and hopefully the technology will work this time. We refer to the spine as the digital backbone of the NHS. little bit of jargon, marketing, but hopefully it gets the message across of what it is all about. So that presentation used to take me half an hour. They've now reduced my presentation to 2 minutes, but hopefully you found that interesting and useful. So a little bit more about the spine. So the spine was built in-house, replaced a legacy service, and it went live in 2014 with a downtime of a planned 5 minutes, which, when you think of it, is quite incredible, given that we had to move 40 terabytes of data, and then given that it's actually taken me nearly 8 hours to download my presentation to give to the tech guys today. That is quite a feat. It's made and comprised of 4 main areas: spine core, the demographic service, which holds 88 million demographic records. That's a longitudinal record, so you have that from cradle to grave. Summary care record holds meds, allergies, adverse reactions, information that's really useful when a clinician in an emergency department, for example, knows nothing or little about you. Electronic prescription service, as you may have seen from the video, that supports 1.7 million electronic prescriptions every single day and growing. And finally, the messaging. So the spine is the backbone of the NHS. All the electronic messages go through the spine. So it doesn't matter if, as an example, you decide to move your GP from one location to another, your electronic medical records go through the spine rather than having to print them out and post them. The other part of the spine service is the care identity service. So you can see these as the keys to the front door. So security is very, very important, obviously. And based on your role, the CIS gives you access to certain parts of spine information. So compared with its predecessor, spine now saves £21 million every single year. It recoups 750 man-hours every single day. Now, I'm not sure what the NHS does with that 750 man-hours. You know, they could make a cup of tea or do other things, but it's an indicator of how successful and how much better it is than the predecessor. And the response times have been cut by 90%. And over the last 2 years, we've had 100% availability, which is very important for systems like this. So everything in spine, in the spine service, gives us a single source of truth about an individual, about a patient, and a platform from which we can enable our digital transformation. And it's also a catalyst to for a wider ecosystem, so that we can encourage the private sector to start to work with us in terms of the things that we do in healthcare. So some of the statistics there, 56% of all prescriptions are now electronic. Community pharmacies have access to summary care record, 96 of those, which is, when you think about it, really, really helpful when you want to check medication, do some sort of reconciliation about the medical record of the individual. Something that I probably need to explain is the CPIS initiative. 44% of local authorities are live with that. CPS stands for Child Protection Information Service. And that is a flag, if you like, or an indicator that a child may be at risk. So really, really important to flag that up to clinicians or healthcare workers. I'll come on to the e-referral service a little later. And 9.6 million people use the GP online service. So that is where they've registered with a GP and can gain access to their medical record or their summary care record. They can book appointments and indeed order repeat prescriptions. So, e-referral service, part of empowering the patient. So it's really good to hear that this is one of the key elements for the future in Poland. For us, it allows the patient not only to choose the hospital, the place that they want to go to have their treatment or the first appointment, but the date and the time as well. That's a huge benefit and a huge difference from where we once were. Other areas of patient empowerment is in the technological landscape. There is an expectation from patients and the public that healthcare is digital. They have it with their online shopping, they have it with banking. So there's an obvious assumption that we also have it for healthcare. I think we're a little bit behind the curve on that one, but we are absolutely getting there. So with 85% of adults having a smartphone across the world, or certainly in the UK, I saw a really interesting survey not so long ago that said, you know, that on average, everybody looks at their phone every 12 minutes. Every 12 minutes, somebody picks up the phone, just checks that there's nothing, they've had no message. So it's really attached to us. So we need to make best use of that. 1 in 10 have a fitness band. And recently, Apple have mentioned the fact that their new Apple Watch will take ECGs. So that's a challenge not only for the patient, but for the clinical world as well, because no longer are patients coming in waving a piece of paper with what they found on Google, but they've got evidence from their watch to say how their life is changing. So we've got to learn to deal with those sort of things as well. And machine learning, artificial intelligence is going to be a much bigger thing in the future, now and much more in the future. So an increasing reliance on digital health services. I mentioned the triage service, the 111 service earlier. So 1.7 million calls are taken by that telephone triage service every month. There are 12 million visits to nhs.uk, what used to be called Choices, every week, and as I say, 1.7 million prescriptions every single day. Digital services in England are growing. I've mentioned some of those areas already. Couple that I haven't mentioned are as the 45.5 million people who have now got access through for free Wi-Fi access. I was a bit skeptical when we announced this initiative, but actually we're seeing to start to see some real benefits of people who are in hospital being able to contact their relatives who are at home. It's very lonely when you're there at hospital on your own, so being able to have connection with the outside world is really important. And then the NHS app, so transaction services and standard integration to other services across the NHS. So that's going to launch later this year. Have a range of services such as symptom checking, so an online 111 service, and appointment booking. And next year, it will be extended to present other health apps in the NHS app library. Supporting the clinician. So I've mentioned some of these services already. So summary care record. So we want to move that to be able to be much more mobile. At the moment is desktop based. We want people to be able to use it on iPads and smartphones. A new service, national event management. So that's a publish and subscribe model where based on an event, it could be a birth, a death. There are some people who need to be notified about that, and that's a new service that we're introducing. National Record Locator, that is very much when you present yourself at an emergency department, they don't really know that much about you apart from what they say. So the ability to put in the system, your name, address, your details, and then pull from across the system, across from all GPs, all hospitals, the interventions that you've had over a number of years is really, really important and useful for a GP, for a clinician. Growing ecosystem. I borrowed this from Graham Gilbert, and I think it's really, really useful slide that shows the health journey from managing wellness, managing illness, and care management. And the care settings, the communication models, and the services that for each part of that journey. Open APIs is one of the key things that we are doing, and we've created an API development portal so that allows developers, whether private organizations or even clinicians, have produced their own apps. I think that's my time is up. They're able to create their own apps and then publish them through the developer portal and the apps library. So that's where we are at the moment. That's increasing, and a lot of downloads on a weekly basis. So that's the NHS now and in the future. I do want to leave you with one last thing, and that is about security. Security and safety of patient information is of utmost importance and paramount importance. And we mustn't become complacent about it. So since I was here in April, those are some of the statistics that have come from around the world, and that shows the number of attacks that healthcare systems have had to deal with. The worldwide impact of WannaCry has been really a wake-up call for the NHS and others, and has shown that it's not acceptable anymore to rely on old technology, old operating systems, things like XP, which I know you have challenges here. So it's something that really we all need to deal with and mustn't forget. So mobile and eHealth is absolutely great, but let's not forget the security. So I hope that's been interesting for you. Have a fabulous rest of the conference, and I'm happy to have conversations with anybody who would like to hear me a little bit more. Not many of you. Thanks.
Thank you very much. You can leave it over there, yes. Thank you. Pan Andrew Meyer, bardzo dziękujemy. Wśród najlepszych w Europie i na świecie, którzy są z nami w Sopocie, jest też pan Vincent van Pelt, od lat zaangażowany w projekty e-zdrowia w Holandii i na całym kontynencie, ekspert holenderskiego Centrum Kompetencji w obszarze e-zdrowia Nictiz. Zapraszam. Please join me.
Thank you. Just a second. I think it's all right. Yeah. Okay. Well, good morning, everybody. My name is Vincent van Pelt. I am a senior advisor at Nictiz, and I'm going to tell you something more about what we are doing in the Netherlands. That's better, right? Yeah. I would like to talk to you today about the healthcare in the Netherlands and a little bit more about our organization, Nictiz. What we see as digital transformation and how that compares to your situation. And then I'm going to talk a little bit about some national programs that we have that might be interesting for you as well. And I end with some lessons that we have learned and that we'd like to share with you. So, but first of all, let me thank you for inviting me here. And we have a long history. Netherlands and Poland have a long history. I'm just picking out two things. In the medical field, for instance, the fact that a lot of thoracic surgeons are in Utrecht in the Netherlands for their education. We have a lot of children who underwent heart surgery in Utrecht as well. And since 1973, the Dutch connection from Dr. Grundeman and for open heart surgery. So, well, short overview of what we are about in the Netherlands. We have 17 million people, a GDP of 700 billion euros, and approximately 10% of that is going to healthcare. That's a huge amount. We are aware of that. So it's a high cost, but also high revenue, because we have a good healthcare in our country. We are in the top 5 of countries from about quality of care. So it's not just that it costs you something, you also get something in return, because we have healthier people, although more and more people are getting bigger and bigger in the Netherlands as well, something that you cannot do only by healthcare. But for the rest, we have, to give you an idea, 90 hospitals. Let's say 5 years ago, there were 100 hospitals, so the number is going down, but they're more specialized and they're bigger. About 5,000 GPs and 2,000 pharmacies. So this gives you a very short overview of the situation in the Netherlands. So a little bit about Nictiz, what we are. We are an organization which is independent. We are funded by the ministry, but we are specifically asked to give impartial and independent advice and help in getting the standardization in the Netherlands up to par. And our motto is we want better healthcare through better information. So we were founded in 2002 as a foundation. We have now 50 employees and we are residing in The Hague. Our main activities are we provide information standards, also for specific fields like childcare or acute care and other fields that are implemented from international standards, but they have to be nationalized to align with all the different requirements that are national. You have an international standard and you make a national copy of that, so to speak. And then we have something else that I'm going to talk to you about a bit later. That's the clinical building blocks. I'll come to that in a while. So that's on the information standards. We also have a knowledge centers, and we have about 50 people, and I think 45 of them are specialists. We have specialists on SNOMED, on HL7, on IHE, and on LOINC and on DICOM, so we have a lot of knowledge in the house, so to speak. Since 2014, we also have what is called an eHealth monitor that is trying to get together all the information about eHealth in the country to see whether we make progress. And we do make progress, and I'm going to show you that also in the next slides. So that's something, it's a tool that you can use to see whether the eHealth actually has effect, that it works. And we participate in a lot of programs and projects, either from our own initiative or working together in national programs or in European ones. Okay, the main question was, for inviting me, how do you see the digital transformation? And well, we have challenges that are different from your challenges, and that has to do with the maturity of your information system. Does everybody have a computer? The use of smartphones is something that was just mentioned. And from there, you see where you have to go. You will find the next challenge. Although we have roughly these stages, this is those are the HIMSS maturity models. This is the situation in the Netherlands, so we're about a 5 on the MRAM and we are a 4 on the CCMM model. But this is just a rough estimation. I mean, there are differences in every field. Although we may be a little bit higher on the ladder, we still have exactly the same problems that you have. You have hospitals and GPs and pharmacies that have their own information system, and they hardly connect. They still have problems connecting. The standards are there, but they are not being implemented. We have a lot of problems like you, so that is something that I would like to share, that even if you are higher on the maturity ladder, you will still see that there's a lot of things that have to be overcome. So from the eHealth monitor, these are some of the numbers that we can give you. Digitization of patient records, so we have electronic healthcare records. The GPs, they have 100% almost an electronic health record. There are 7 vendors who sell the the GP information systems, but they have one underlying standard for exchange of the basic information, sort of the patient summary. Specialists, on the right-hand side, you see the number that is growing. And now it's up to 90%, and that's also going up. So 90% of the specialists now also use electronic medical records. Nurses, 75%, and nurses in care, that's just 31%, so we have to work on that. On the subject of medication interaction warning, so that you are being warned when something is wrong with the medication, or may become wrong, the GPs, they almost all have the warning systems installed, and the specialists are also getting more and more of that. So ICT can help you prevent making mistakes with medication. The effects of these transformations to digitizations are a higher quality of care, and that is without any doubt, because you can find the information, you can share it, you can use it in quality assessments, etc. And that also means that you have increased safety. There are no written things that you cannot read, and the doctors are very bad at writing. I don't know why. But if you put it in a digital way, then it's much more readable. And you would expect that you would get less administration if you have electronic systems. But that is not really the case. About 33% reduction, where we would like to have more reduction. But if you have computers and managers see that you have data, they want to get that data together to get a grip on healthcare. So there's extra administration necessary. There are hospitals that have 150 different quality forms to fill in. So there's a lot of bloat of information that needs to be filled in by the doctors as well. So that was digitization. And how is it going with the exchange of information? Because you have a digital system, but how do you exchange information? And exchange of information is becoming more important because chronic healthcare, an aging population means that patients go from one hospital to the other. They have multiple diseases. So for them it becomes rather a blur what they should do, who they should talk to. And for that, information exchange is really necessary. You see here the percentages also from the eHealth monitor. And what you see is that some parts are really going very well and other parts are lagging behind. For instance, the connection of the GP and the specialist with the patient is still low, 5%. You have possibilities for patients to be monitored by special monitoring services. You have the opportunity to write a mail to the physician and then you get an answer. And you also can do face-to-face meetings, but that's just 5%. And that's something that the ministry has decided to change. And there's a new initiative that has started in 2016. It's called MedMij. And the aim is to get 80% exchange in 2020. Actually, that is one of the goals of the government, to have that realized. So that is one of the focus points for the eHealth transformation challenges in the Netherlands. First of all, the continuity of care, because the exchange of information is there, but it's not good enough, it's not one system, it's not a network, and not everybody is involved. So we need to improve that part. Empowering citizens, as I just mentioned, that is necessary for patients to take part in their own healthcare, to be informed, to be empowered by their knowledge and to be more responsible for their own disease. That is something that we are currently working on. The third part is upscaling interoperability. We have in the Netherlands a rather mishmash situation. I'll talk to you about that later. So these three parts are going to be on the next slides. The Dutch government, they have had a rather laid-back role in the last couple of years, but now, since 2015, they've started what is called the Dutch eHealth Information Council. And literally, that's where every month or every 2 months, the government comes together with all relevant stakeholders. So there's a whole system in the room. You have physicians, you have specialists, vendors, you have insurers, you have all the divisions in healthcare. And in this process of the eHealth Information Council, they propose new changes. And then the Information Council is being helped by expert teams. And then after a month or 2 or 3, they say, okay, this was a good proposition. We're going to invest in it. We're going to tackle this problem. And that is something that is really working. It doesn't always go fast, but it works. And we have had some major changes in healthcare already, with also, might I say, a lot of funding. So the programs for the National Health Information Council are to improve the personal health environment, to improve data exchange, the little bits of data that you need to exchange which are structured and standardized. That is an important part. And infrastructural common services. Funding is also part of the program, and there's a funding for delivering personal health environments, called personal health environments because a personal record is just a record, and this is more than just a record. For hospitals, for example, the ministry has given 105 million euros to hospitals to open up their healthcare systems to the patient. So all the hospitals have provided a portal, and the patient can log in, and then he can see his or her own data. That's something that's going on in the next 2 years. GPs, they also have a program for roughly in the area of 10 million euro for funding for opening up their systems. And the same goes for mental health care and infrastructure. Those are still ongoing, so there are no numbers that we can attach to that. The continuity of care is something that has already come in the previous slides, but I'd like to convey to you some changes in the way that healthcare works. It used to be a one-on-one situation where the patient talked to the doctor and that was it. And the doctor was the person who guided healthcare, usually sent the patient off with some pills and said, if you get more problems, you come back to me. Whereas now, you get more like a network of networks, where a lot of people around the patient, not just the physician, not just the GP, but also the physiotherapist, the caregivers, the family members are all involved in the healthcare of the patient, because disease is more and more a chronic situation, where you're being served by the healthcare in just a short amount of time, and the rest of the time you just have to do it yourself, or by help from others. And if you talk about continuity of care, this is, I think, a slide that you already know, as Artur told me. If you need continuity of care, you have to have interoperability. Now, interoperability is a hard word, and it's also hard work to get it done. It basically means that you don't just try to connect a few plugs and then you have your interaction and your communication. It's much more. You need to align and have agreements on many different organizational and conceptual levels. On the legislation approach, what do you do with security, with privacy, with the GDPR? Those are some things that you have to make agreements upon. Policies from hospitals that they, for instance, want to share information between each other. In the Netherlands we have regional XCS affinity domains that are hospitals that know each other, so they trust each other. So they start small, but now these regions want to exchange information amongst each other, so it's sort of growing organically. An information layer where you have common data modeling, the application layer where you have agreements on what kind of HL7 or other protocol are we going to use to exchange information, and of course the common infrastructure. It's not just that you have to make agreements on all these levels between organizations, but it's also that you have to involve all the different stakeholders that are involved in getting interoperability done. So as I said, it's not just a hard word, it's also hard work. So, yeah, what is this? Actually, I was surprised by this little figure because it represents the number of hours that a patient with diabetes, thank you, the number of patients with diabetes that are being served by a healthcare professional and the time that he spends on just doing it himself. And that is something that is rather, well, that makes it clear that you need to do something with all these other hours where the patient has to be sort of his own specialist, so to speak. And to get this done, you can use eHealth. You can use all the different things that also Andrew pointed out. Use modern software and modern techniques to bridge the gap between the time that you see a patient as a doctor and the time that the patient has to do things for himself. So that is something that I think is a nice image, this one. I'll just flip through this because my time is up. Just as an illustration, all the different networks are now not connected. And there's a lot of apps and devices and networks and platforms that are all providing services for the patient, but and also have similar functionalities, but none work together. They're not one system, they're not one network. So what you need in the personal health environment is sort of a dashboard environment where a patient can see all the relevant information about his or her health in one overview. And this informs the patient, it gives him power, oh, I'm looking at the wrong button. Gives him power to engage in his own health, and that also helps put the number of complications down. Okay, I'll leave it at that for the time. Thank you very much for having me, and I hope to speak to you again. Thank you.
Thank you very much.
You're welcome.
Oczywiście warto podkreślić, że w naszej nieformalnej atmosferze konferencyjnej są też przerwy. Konferencja jest dwudniowa, więc będzie oczywiście okazja do pytania, do podzielenia się swoimi doświadczeniami. Nasi uczestnicy, zwłaszcza z tej części reprezentującej inne kraje i inne doświadczenia, są cały czas do Państwa dyspozycji. I jeszcze jeden z nich, tym razem z Austrii, pan Jurgen Brandstätter, współprzewodniczący eHealth Europe, lider i współtwórca globalnych standardów e-recepty, eHealth Pharmacy Domain, promotor opartej na standardach interoperacyjności, która pozwoli na wymianę informacji medycznych w Europie i na świecie. Jego także postanowiliśmy zapytać, jak skutecznie wprowadzać cyfrową transformację i czym ona jest. Brawa, prosimy. Dzień dobry.
Yeah, good morning. Also from my side, I'm, as you see, one of the two co-chairs of IHE Europe. I'm feeling privileged to be invited to this forum to give you a perspective on the digital transformation out of a global ethic standards organization. It's a bit hard to stand against these two brilliant presentations from before, especially Andrew, your video makes it very challenging, to be honest. But what I can provide to you is a kind of a global perspective on that topic. So we don't have details on one specific country, but I think it's useful to see where the global trends are in terms of that. So you see, digital transformation is, of course, electronic health information exchange. But it's also devices, for example, and we have IoT. And IoT, some deem broader than just healthcare, you know, because a weight device, is it a healthcare device or is it a household device? But still they are connected to our wireless at home. So mobile health, the next huge trend in the future, but also some not clinical related things like appointments and other organizational things. All this falls under digital health transformation healthcare. So to get that all done, we have already heard multiple times, I guess, that interoperability is a hard word. You were right. Is key. It's essential for digital transformation. And you have heard that, and I hope you believe that. So interoperability was a big topic in the European Union already. So for several years, there are working groups working on that. And as we heard before, this is just another representation of the same message, is that interoperability is far more than just techniques and bits and bytes. We have these three layers of interoperability, and this was designed by the eHealth stakeholder group, which was a consulting group to the eHealth network, where all the European countries, the ministers of health of all the European countries are taking part of. So we have these three layers, organizational, semantic, and technical interoperability, and you need all three actually to have some success. So organizational, I guess you'll know, is most complex and lengthy, and this is the area where you have most of the politics. You have some politics everywhere, but this, of course, is the layer where you have the most tricky ones. So actually, in this layer, you have to get all your stakeholders to voluntarily and enthusiastically pull on the same string, and most important, into the same direction. In my home country, they pulled on the same string, but often in different directions. So, but in the end, you must achieve that everyone steers toward the same direction. That's important. Semantic interoperability is hard from a content perspective because it goes far into the clinical practice. In my home country, Austria, for example, we had a lot of debate on the different terminologies, because physicians are used to use this or that terminology for procedures or for diagnosis, for whatever. And it's hard to convince them to switch to another unified system. But you need this system in a nation so that you have semantic interoperability. You need to get the people agreeing to these other new terminologies. So this is a challenge which we see is a challenge in every country. And of course the technical interoperability layer, but this is low complex, to be honest, because it was a problem, let's say 10 years ago, but it's not anymore. So I see that later, I have a slide on that later. Standards and best practices are already there. So the saying, what I have on this slide everywhere is creation of health information exchange is not the problem anymore. It was 10 years ago, but it's not now. You can almost buy it off the shelf if you want. The problem is, at the moment, how to do it most efficient and sustainable. This is the challenge. And this is where we as a standards development organization see our own, let's say, biggest demand in our messaging, to try to educate and consult potential users of our standards how to do that most efficient and sustainable. So these are the aspects of the challenge you of course know. You have different stakeholders. So you have hospitals or even hospital trusts, which have the tendency, for example, to connect all their hospitals within their reach for example, with one vendor system, which makes sense. I mean, you get a better price. Of course, you are in the hand of this one vendor for a long time. It has pros and cons. You have GPs, usually many small entities. It's much harder to supply all of them with a one vendor solution. So they usually have their many, many different small vendor solutions which you have to connect. Specialists, pharmacies. Pharmacies have another business. They are not doctors, they're pharmacists. And nursing homes. You have different vendors for the same kind of software, and you have different vendors because it's a different kind of software. So you have to deal with those two levels on the vendor perspective. So if you have vendors with the same kind of software, you have competition. That's good. Competition is good because it's lowering the price. Different vendors because you have a different kind of software is a matter of fact. If you have a hospital information system, you might maybe have one which has also all of your needed PACS, for example, functionality. But often this is not the case. PACS is something different, and you need to make sure that also in your hospital you get these things interoperable. You have usually in a country a federated topology. Honestly, when I am on international conferences and I hear nations speak about their health systems, I almost feel like in a competition. And the competition is named, which one is the most federated country? And believe me, there is always the next one which is even more federated, as yourself have thought that your own country is the most one. So, of course, my home country is the most federated one with 9 provinces on just 8 million people. And then I learned that Switzerland has the same amount of people with 27 cantons. So there is always one who is any more federated, but the success is they're all federated on the different levels, on country, state, province, city, provider, and even facility level. You have in every country usually a public and private sector in different dimensions. So my home country, for example, has a large public sector and a relatively small private sector. In other countries, it's the other way around. In some countries, you have almost just private, like in Hong Kong. Almost everything is a private sector, just a little bit is government. And what you have everywhere are complex use cases. So the use cases are usually not, I have something to transmit from A to B. I have processes like e-prescription. You issue a prescription, you maybe want to change this prescription before it is dispensed. You dispense it partially, and then you dispense it again, the rest of it. So there is a complexity. And this complexity will not disappear because you pick this or that standard. So you can pick, and you should pick a standard. But don't believe that there is a silver bullet which makes super easy. I know every one of us seeks for these easy solutions, but they are not there. The complexity of processes of e-prescription or e-refer or all the others are as they are at any time. And with these new upcoming applications, there are even unknown complexities in front of us. So I was saying, and what we see that some countries already tend to, some countries are still hesitating, but what we see that is a trend or should be a trend is that you see healthcare health information exchange as part of your infrastructure. And that's, by the way, like the European Union sees it. If you look on the doings of the European Commission and all the announcements, you see they have announced the digital service infrastructure as a, let's say, overall project, not only healthcare. It's also, I know, e-identification and e-justice and all other verticals and aspects. but also healthcare, of course. So the clear thinking is, let us create an infrastructure like a road or a pipeline where information can flow, and let's organize all applications of the different kind, e-prescription, sharing clinical documentation, e-referral, as applications on top of it, using the same wire, so to speak, on the bottom to save costs. And some countries are in line with that. For example, Austria is thinking like that. So we have established exactly that, an eHealth infrastructure. So establishing that is a huge financial investment, but it doesn't feel as huge if you think of it as a piece of infrastructure. If you talk about a road, let's say 100 million euro for a few kilometers motorway, everyone says, yeah, it costs that much, no problem. For the development of the Austrian national e-health infrastructure, there was a budget outlined of 30 million euro, which is compared to building a road almost, it sounds like a joke. But it seemed to people very big, and it is actually a very big number, honestly. But compared to what was achieved, that we created a piece of infrastructure, it was relatively cheap. And the cost factors are very much, you have initial cost factors like creating the interoperability specifications, doing all the tendering and procurement, and the testing to get that thing online. But you have also ongoing costs, which are maintenance, improvement, new services, and testing. Again, testing. And I'm stressing that because IEG, the organization I'm with, is about testing. The point is, testing is a cost factor which is huge, and you don't get rid of it. You have it as long as you have this thing online, because you're constantly onboarding new participants to the system. So every % of effort you save here at these 5 points saves you a huge amount of money. And that's our reasoning why you should go on standards, which are already there. So most of you, I think, have already heard what IEG is, but this is kind of the short summary of it. So accomplishing an eHealth use case requires the combination of standards, and the question is how to combine, how to compose the standards to achieve the use case. And that's why IEG is stepping in. So we are picking the right standards for the use cases. Let's say this fire resource shaped in that way, constrained with these constraints, together with this other fire resource to accomplish e-immunization, for example. This is the work of IEG. So we are an intermediate layer. And we are also dealing with the testing. So this works like this. We have the standards, we create profiles, and they should walk into the national interoperability specifications, as you do it in Poland, by the way. And then the story continues. Products are created according to this, and they are tested according to this, and only then they meet again with the project up there for making projectodons and make that thing working exactly in the country. And this is how we believe the most efficient way how to do that, because most of the costs are done in the lower level by the vendors on their own, one time for all, and the eHealth projects on the top have just to deal with the remaining costs. Okay, so if you have all that in place and you have maybe already starting doing your rollout, then you are advised, as fifth advice, to incentivize your stakeholders. We see that this is almost happening everywhere. As honestly, I personally have not seen a country where this is not happening in the one or other way. So how is this done? So usually there are 3 methods to do that. You can do a one-time investment support, so one shot of an amount of money, or you pay according to the actual use of the digital applications, or you bind your incentive to the health outcome, which is related to it. So the impact is rather roughly said like this. So the first one has a very limited impact, but at least you get all the stakeholders connected to the system usually. The actual use has a medium impact, and the healthcare outcome and quality would have a high impact. The problem is and it would also have, of course, let's say, good implication on what you want to achieve. The challenge is the one-time shot is very easy. You just bind it to something, and then you pay the sum, and that's it. For the actual use, there are many hidden complexities, because use does not mean that it makes sense how you use it. So how to measure if the use is really meaningful? If you bind your payments to how often does a physician call up the health record of a patient, then okay, but for what reason does he call it up? Just for getting your incentive, or for really reading through it and making some use out of it? So there are a lot of hidden complexities in this approach. And the health outcome quality related approach would of course be the best, but it's very, very hard to measure. We have Italy, for example, has a kind of culture in measuring that. It's in their blood, so they measure everything. So that's really good, but they are pretty much the only ones I know which are doing that to that extent. For example, Austria, my own home country, has no measurements of that kind, because it's very, very complex. And it's maybe, it's not good that we don't have it, but we don't have it. So this is an overview about the incentives in the different countries. So in Austria, for example, we have this one-time funding. So rather low, 1,350 euro for a GP. The hospitals do not get incentives. Yet anyone thinks this is a good deal. It's okay, and the physicians do connect to the system very gladly. In Australia, they have bound the incentives to accreditation. So they need to have their systems accredited against a set of criteria, and if they do that, they get an incentive. In that case, a quarterly lump sum. You see all the details if you click on the links. In the US, you have had the meaningful use program. It's still online, honestly, or will be ramped up in a stage 3 soon. And there you see, oh, my ship is coming. Just one more minute. They have spent a lot of money, billions of dollars in incentivize. And they have the good success. They have a good rate of connectivity now. But they spent a lot of money. I mean, $30,000 per professional in average. I mean, that's 30 times more almost as we spent in Austria for achieving the same. So I don't want to judge if that's wise or not wise. I just give you the numbers. And other countries are doing it different. For example, Switzerland has simply issued a law where they say a citizen has to have the ability to create a health record on its own. That's enough, because this forces everyone to provide the possibility to do that. So that's a very innocent way to do that. And Ukraine and Philippines, for example, they bind it to reimbursement, which is also very clever. If you don't issue a reimbursement claim electronically, you just don't get the money. That's it. So this raises a lot of intrinsic motivation to do anything. So there are several ways to do that. And then you can harvest your benefits. So these are some actual numbers from Italy, from the Veneto region. It's very impressive. For example, they have a cost saving of 56 million euro in 3 years because of introducing the sharing of clinical documentation. And they have really measured that. That's not guesses or estimations. They have measured it and calculated it. And out of their e-prescription system, in 5 years, they have a gain of 10 million euro. You know, just paper and all storing of these things and so on. And you see that the two diagrams, you're very soon in the black numbers here. So I'm at the end. Just one thing. There is a new initiative which is called Global Digital Health Partnership, and this is a message more or less to your government. I'm privileged to participate this initiative on behalf of my home country, Austria. You see, it's 18 countries now, plus the WHO in this forum, plus 3 are getting onboarded right now. And you see, these are the 5 streams this group is dealing with. Cybersecurity, we heard before. Clinical and consumer engagement. Evidence and evaluations is exactly the topics which are so interesting for every country. And it would be great, to be honest, if Poland could decide to join this governmental group. By that, I come to the close, and thank you very much.
Bardzo dziękujemy. Ja biegnę po drugi mikrofon, bo będzie nam teraz potrzebny, albowiem jest z nami pan dyrektor Pruszko, którego już przedstawiłem, ale nigdy dosyć. Artur Pruszko, dyrektor i współtwórca Forum Zdrowia. Skąd inspiracja do stworzenia forum?
Szanowni Państwo, po pierwsze bardzo, bardzo dziękuję za Państwa uczestnictwo, i odpowiem trochę Panu Ministrowi, bo naszą inspiracją do podjęcia kwestii e-zdrowia nie była technologia. Zaczęliśmy kilka lat temu, ja dołączyłem do grona, do środowiska, które zajmowało się zintegrowaną opieką i zaczęliśmy rozważać kwestię, jak to się może stać. Wpadliśmy na koncept i powołaliśmy Centrum Zintegrowanej Opieki i e-zdrowia. Dlaczego e-zdrowia? Bo doszliśmy do wniosku, że zintegrowana opieka się wydarzy tylko wtedy, kiedy połączymy te wszystkie rozsypane fragmenty ekosystemu e-zdrowia i tutaj informacja i obieg informacji i digitalizacja jako pewien sposób funkcjonowania jest kluczowy. Także nasze inspiracje nie pochodzą z technologii, nasze inspiracje pochodzą ze strony klinicznej, ze strony opieki nad pacjentem i zaadresowania bardzo złożonych kwestii zdrowia i kwestii zaangażowania pacjenta. To, co pokazywał Vincent na slajdzie, który mówi, to pacjent zarządza swoją chorobą. Lekarz, pielęgniarka są mu pomocą. Oczywiście w końcowym etapie pewnie bardzo dużą pomocą, ale tak naprawdę to pacjent żyje ze swoją chorobą i to on musi być po pierwsze odpowiedzialny za własne zdrowie. Stąd ta nasza inspiracja zupełnie technologiczna i najprawdopodobniej e-zdrowie zaraz zniknie i będzie po prostu cyfrowe zdrowie.
Czyli można powiedzieć, że przewodnia idea to w całej tej dyskusji trwającej już od kilku lat, zwłaszcza tu, to zmiana sposobu myślenia.
Zmiana sposobu myślenia, zmiana kultury, zmiana funkcjonowania nas wszystkich.
Wydaje się, że wszyscy powinni być zainteresowani udziałem w takiej dyskusji, ale różnie bywa, czy tak było też tym razem, czy wszyscy chętnie wzięli się do dyskutowania i wypracowania wspólnych rozwiązań?
Jak to w życiu? Różnie było. Chciałem powiedzieć, że na początku w 2016 roku była grupa osób, są tu niektórzy z nich z nami, odnajdźcie je Państwo tutaj, którzy byli na tyle odważni, aby tą dyskusję podjąć i kontynuować ją przez te lata, aż do dzisiaj 2018 roku, jak Pan Minister wskazał, może i dalej. Także budujemy powolutku kulturę współpracy i współdziałania. Po angielsku interoperacyjności, ale po polsku współdziałania. Kultura współpracy jest trudna, znaczy to trzeba zbudować. Ona wymaga po pierwsze zaufania, po drugie szacunku dla siebie nawzajem, rozpoznania odrębności i uznania tej odrębności. I na końcu to jest bardzo ważne, takiej uważności na siebie nawzajem, że trzeba być wspierającym. Znaczy w tym networku, jeśli on ma działać, trzeba wspierać się nawzajem, wyprzedzając jakby oczekiwania i potrzeby, rozpoznając potrzeby innych partnerów tego ekosystemu.
A jako prekursorom tej dyskusji, jako prekursorzy macie ten przywilej możliwości zdefiniowania tego, co w tej chwili w tej dyskusji jest najważniejsze. Tutaj w jednej z tych prezentacji padła taka myśl, że nie samo stworzenie systemu, bo to jest już relatywnie łatwo osiągalne, tylko stworzenie tego jak najlepiej, jak najtaniej, jak najbardziej efektywnie. Czy to jest to?
To jest jeden z ważnych wymiarów tej dyskusji. Pozwoliłem sobie dla Państwa przygotować dwie inspiracje z naszych rozmów, które mogą posłużyć również i nam w tej debacie. Więc jakbym mógł... Gdzie jest nasz zmieniacz? To nie będzie długie. Więc to jest nasza debata interesariuszy działających na rzecz wykorzystania potencjału e-zdrowia. Tak wygląda nasz system. On jest złożony, skomplikowany. Tak naprawdę pacjent wędruje pomiędzy różnymi fragmentami systemu i każda z tak naprawdę z tych obszarów może oznaczać kilkanaście podmiotów. W trakcie swojego życia pacjent korzysta z różnych szpitali, z różnych lekarzy i to wszystko tak naprawdę to jest ten nasz ekosystem, który musimy połączyć i on naturalnie jest zróżnicowany i w pewnym sensie sfragmentowany albo połączony. Sieć ma to do siebie, że ona ma oczywiście te punkty, ale w sieci jest więcej strzałek niż punktów. Także połączenia tak naprawdę decydują o jakości sieci. Co więcej, jak pomyślimy sobie, jak będzie wyglądała ta sieć w przyszłości, to ona będzie zawierała nowe elementy, których nie było wcześniej. Jeśli my myślimy o systemie e-zdrowia, to przeważnie myślimy w kategorii POZ, AOS, szpital i tak dalej. Ale on dzisiaj wygląda zupełnie inaczej. Duża część tych strzałek, które są narysowane, czyli relacji między pacjentami, między różnymi systemami, które wspierają pacjenta, już jest poza tym obszarem i to się będzie cały czas powiększać, żeby to wymienić chociaż to samo leczenie wspierane sztuczną inteligencją, algorytmami, czy sieci społecznościowe, czy jeszcze pewne rzeczy, których jeszcze tutaj nie ma. Właśnie, owa otwartość na przyszłość, owa elastyczność, to jest to podejście, które nam przyświecało. I tutaj odkryliśmy IHE jako partnera, który ma w sobie tą właśnie właściwość, że buduje otwarte, federacyjne rozwiązania, otwarte na przyszłość, elastycznie mogące odpowiadać na potrzeby zmieniającej się rzeczywistości. Chciałbym Państwu pokazać dwie formuły objaśniające, przynajmniej dwie formuły objaśniające cyfrową transformację. Jak mamy jakieś zjawisko, to możemy myśleć o jego symptomach albo jego przyczynach. Jak leczymy, to możemy liczyć objawy albo przyczyny. Czasami różne choroby mają te same objawy. Różne zjawiska mogą mieć te same symptomy, ale też ci odnoszą chyba sukcesy, którzy tak naprawdę sięgają głębiej i zobaczą tak naprawdę, jakie są przyczyny tych zjawisk. Chciałbym zacytować dwa takie inspirujące obrazy. Pierwsza formuła, właśnie, dlaczego tak trudno odnosić sukcesy, objaśnia jakby tą kwestię. Cytuję to za Halem Wolfem, obecnie szefem HIMSS-a. Jeśli pomyślimy o cyfrowej transformacji, to mamy pewien zastany porządek rzeczy. Nazwijmy go starą organizacją. Jeśli do tego dołożymy ową cyfrową rzeczywistość, nowe technologie, to jak myślicie Państwo, co my możemy otrzymać? No, chciałoby się myśleć, że otrzymamy coś nowego, nową jakość. W istocie rzeczy, jeśli do starej organizacji dołożymy nowe technologie, to otrzymamy kosztowną, starą organizację. I jeśli zastanawiamy się nad źródłami naszych porażek, to czasami warto spojrzeć, ile w tych porażkach jest po prostu starej organizacji. Ile jest próby scyfryzowania świata, który tak naprawdę powinien odejść. W pewnym sensie powinien być zastąpiony przez nowe rozwiązania, nowy świat. Właśnie, czy możemy temu zaradzić? Istotnie możemy temu zaradzić, jeśli zaczniemy transformować nie tylko technologiczną stronę tego równania, ale również tą organizacyjną stronę tego równania i na to zwracał uwagę Jurgen w swoim wystąpieniu, mówiąc, że najtrudniejsza jest ta warstwa organizacyjna interoperacyjności, czyli współpracy. Vincent pokazywał model, który został wypracowany, który też pokazuje, jak wiele poziomów tej współpracy jest potrzebnych, żeby przetransformować organizację. Okej. Kolejna ważna informacja to jest to, że w naszym przypadku my nie transformujemy organizacji. Znaczy, wielu nas pochodzi z jakichś z organizacji biznesowych i wiemy, jak trudno jest przetransformować organizację. 100 000 pracowników. To jest wyzwanie. Nie? System ochrony zdrowia ma prawie 1 milion, rzędu 1 miliona pracowników, 700 000 pewnie. Więc my, szanowni Państwo, nie transformujemy organizacji. My transformujemy ekosystem. Inne narzędzia i inne sposoby powinny służyć transformowaniu ekosystemu. O wiele bardziej wyrafinowane niż to do transformowania organizacji, które samo w sobie jest potężnym wyzwaniem. Także jeśli chcemy transformować łącznie system, to znaczy musimy być bardzo, bardzo precyzyjni w tym, co my transformujemy, czyli cały nasz ekosystem ochrony zdrowia. No dobrze, ale czy możemy oczekiwać lepszych rzeczy? No, chciałoby się powiedzieć, i to już nie ma tutaj Hala, myślę, że to jest nasze oczekiwanie, nasze życzenie, że mając przetransferowany łącznie ekosystem i nowe technologie, otrzymujemy nowy cyfrowy ekosystem. Panie ministrze, jeśli będziemy robili konferencję, to może o tym nowym cyfrowym ekosystemie, a nie o e-zdrowiu. Dobrze, to była pierwsza inspiracja. Chciałbym powiedzieć Państwu o drugiej inspiracji, która to było trochę o opisaniu przeszłości, o tym, jak ponosiliśmy porażki, jaka jest przyczyna tych porażek, tak? Nie symptomy, ale przyczyna. Ale zastanówmy się teraz trochę nad opisem tego, co może się wydarzyć w przyszłości. I tutaj chciałem Państwu zaproponować taką formułę, która została opublikowana w raporcie. Działa? O właśnie. Cyfrowy świat przynosi nowe korzyści w kreowaniu wartości. Jak to zostało opisane? No dobrze. No tu jest taka bardziej skomplikowana formuła. Jak może wyglądać rzeczywistość? To taka formuła, jak ktoś trochę lubi analityki potęgowo-wykładnicza, mająca innowacje i dane. Data jako aktywa. Cóż wchodzi w innowacyjność tutaj tak rozumianą? Raport Progression Life Science 4.0. Mówimy o gospodarce 4.0, możemy mówić również o ochronie zdrowia 4.0. Innowacje. To po pierwsze outcomes, czyli to, co otrzymujemy w wyniku naszych działań i personalizacja. Cyfrowy świat daje nam lepszą perspektywę personalizacji. Otóż te same symptomy mogą być powodowane różnymi chorobami u różnych osób. Personalizacja działania. Różne konteksty tego działania, czyli personalizacja kontekstu. To wszystko jest w podstawie tej formuły kreowania wartości. A druga rzecz to jest właśnie ten świat połączony, świat danych jako aktywa. Wiemy więcej, podejmujemy lepsze decyzje. Działamy sprawniej, działamy wspólnie, czyli connect, combine and share. Pomyślmy sobie, czy ta formuła nie opisuje przyszłości i walidujmy nasze działania taką formułą. Zobaczmy ex ante, czy nasze działania są dobre. No właśnie, to była druga inspiracja naszego spotkania. Będziemy rozmawiali o tym, także szanowni Państwo, bardzo serdecznie dziękujemy razem z panem Piotrem Popowskim, który jest szefem Centrum Zintegrowanej Opieki Zdrowia Gdańskiego Uniwersytetu Medycznego, za Państwa obecność i życzymy właśnie inspirujących spotkań. Dziękuję bardzo.